Okay, so the client is a 34-year-old female half and full marathon distance runner. She is 1.61 meters in height and weighs 45.2 kilograms. Also, based on her body mass index, her body fat percentage has been estimated as 15%. Background theory within the female athlete. A trend of low energy availability has been found within female athletes. An athlete is considered to have a low energy availability when their energy intake is below 30 calories per kilogram of fat-free mass per day. This has been found to be caused by a variety of different factors, such as personality factors, injury, and pressure of weight loss within sport. Research has found that low energy availability causes a variety of problems, which has been coined as the female athlete triad. This includes disordered eating, amenorrhea, and bone loss or osteoporosis. Whilst it's been found that these symptoms can be developed separately, it is usually the case where if one of them is present, the other two soon follow. The International Olympic Committee stated that disordered eating should be diagnosed using diagnostic criteria which can be found in their position stand, but also should be diagnosed if restrictive weight loss practices are present, or the athlete is in negative energy balance. They have also stated, based on previous research, that female athletes show a higher prevalence to disordered eating than male athletes and females who are not active. Moreover, female athletes have been found to have to show signs of amenorrhea and bone loss. This is due to the body stopping certain physiological functions to reduce the energy deficit, but this does not increase the energy availability. Bone loss is also caused by inadequate calcium consumption and vitamin D consumption, as well as the reduction of estrogen, which leads to remodeling of bone and in turn bone loss. Recent studies have extended the theory of the female athlete triad and developed the theory of a syndrome called relative energy deficiency in sport, which further explores the effects of low energy availability on athletes, female and male. These relative energy deficiency in sport causes effects such as increased injury risk, depression, reduced glycogen stores, which in turn leads to reduced endurance performance. Okay, in relation to insufficient energy intake, it has also been linked to low iron intake, as on average it has been found that 6 milligrams of iron are ingested through when 1,000 calories are ingested. The American College of Sports Medicine, or the ACSM, has stated that female athletes can require up to 70% more than the estimated average requirement, and that distance runners are also a group that are at high risk of iron deficiency. Lastly, nutrition has been identified as the first treatment which should be considered before other treatments are considered. Okay, so the impact of this theory on the client, and what is apparent in the client, is that she clearly has a low energy intake and a low energy availability. This is most likely why she is showing symptoms of the female athlete triad and the relative energy deficiency in sport syndrome, such as increased injury risk and bone loss suggested by her stress fractures, She has shown signs of amenorrhea, which she has had for 2 years now. She has also shown symptoms of disordered eating and anemia. So she has already been diagnosed with anemia, which she is more susceptible to, as shown in research, as she is a female athlete and a distance runner. This may be very detrimental to her health and her performance, as it reduces the amount of hemoglobin in the blood. Therefore, her cardiovascular system is hindered, and so is, in turn, her endurance performance. Lastly, the previous symptoms mentioned and her restrictive weight loss strategies, as well as her fatigue without caffeine, supports the idea that she has got disordered eating, as seen through the diagnostic criteria from the International Olympic Committee. So following nutritional analysis, her energy intake is a major cause for concern, and is possibly the reason, or biggest reason, why she is showing the symptoms of the two syndromes. She showed nutritional analysis revealed deficits of between 818 to 1,890 calories, depending on whether she is training or resting that day. Her carbohydrate intake has also been identified as inadequate and is far from her optimal for her performance level. However, protein and fat have been identified as adequate, but fat may need to be increased when calories are increased to ensure that she is getting 20% of her calories through fat. Following on from this, water has been identified as inadequate, but it is not a primary concern, which will be discussed later. With iron, she has already been identified as anemic. However, the nutritional analysis has revealed and confirmed that her iron intake is inadequate, which will need to be addressed. Lastly, her calcium and vitamin D intake are also inadequate, which will need to be addressed to optimize the recovery of her bone health. In relation to the recommendations that I have provided for the client, for weeks 1 to 3, I think the client should be considered as injured and refrain from training due to her disordered eating. This is what the International Olympic Committee recommend, as it will reduce her energy expenditure and so mean that she reaches positive energy balance more rapidly, ensuring that her recovery of symptoms is more rapid. So her first aim for this period is to increase energy intake and carbohydrate intake gradually. She should increase energy intake in manageable increments of 300 calories, which is what ACSM recommend. So 300 calories daily per week will ensure that adherence is promoted, as it is a more realistic increment, and mean that she is ingesting more than her resting metabolic rate and has optimal energy availability for a rest day by week 3. So the majority of these calories should be ingested through carbohydrates, which will mean that 2 of her major concerns can be addressed in the same simple changes to her diet. These can be done through the implement of shakes, such as the blended smoothie as shown on the handout. This will provide her with around 50 grams of carbohydrate and over 300 calories, whilst not making her feel heavy or slow, which she said she does not like. This will also increase water and iron intake. For this reason, the increase in energy intake, water intake is not a primary concern, as it will increase through food sources as she eats more food to increase calories. The second aim for this period is to increase iron intake gradually by 3 milligrams a week. This can be done through introducing more red meat into her diet, such as shown on the fridge guide. She can swap her 100 grams of chicken breast for 100 grams of steak, which will provide her with 2.4 milligrams of iron instead of the 1 milligram of iron she is getting from the chicken breast. She can also introduce iron-rich vegetables and legumes, such as chickpeas. She can cook into her spaghetti bolognese, which will provide her with 6.1 milligrams of iron and also increase her calories and carbohydrates. For the second period, weeks 4 to 6, the client may resume training as long as she has met the energy intake recommendations and is not showing any symptoms of disordered eating. So the first aim for this period will be to maintain energy intake on rest days, which was reached in week 3, which will be about 1,800 calories, which will provide her with optimal energy availability. Also, because she is resuming training, she will need to compensate for that extra energy expenditure on those training days, which she can calculate using the energy intake compensation handout provided, which provides the energy expenditure for her most common training practices and activities. Her second aim will be to maintain iron intake at 18 milligrams a day, which is the ACSM guideline for optimal iron status in female athletes. The last aim for this period will be to increase calcium and vitamin D consumption gradually to optimize her bone health recovery. This can be done through incorporating dairy products and vitamin D and calcium fortified foods. So what can be used is the cornflakes and semi-skim milk recipe in the fridge guide, which will provide her with 226 milligrams of calcium and 4.2 micrograms of vitamin D. So in relation to monitoring and the evaluation of the intervention, I will ask the client to complete a daily energy intake diary, which will promote adherence as it serves as a reminder and a motivator for the client. Also, the weekly one-to-one check-ins to discuss and evaluate the progress and the intervention will allow me to build a rapport with the client, which will make her more comfortable in discussing her opinions and problems with the intervention, which we can then fix. As recommended by the International Olympic Committee, dual energy X-ray absorptiometry scans will be used to monitor any changes in bone mineral density. These would be done before the intervention, week 3 and week 6, to track her progress. Also, regular blood tests will be used to monitor iron status as recommended by the ACSM, again being done before the intervention, week 3 and week 6, and it will allow for her to be seen by a doctor to monitor her anemia. Okay, so in relation to safety and legality considerations, the International Olympic Committee suggests that a health professional has a duty to prevent any activities which promote weight loss to athletes. Also, they say that if symptoms of disordered eating are present, then the athlete should refrain from training and competition and be considered as injured so that they are not at any risk of injury or other factors. Also, UK Athletics, UK Sport, and the World Anti-Doping Association suggest that food sources should be used ahead of supplements to ensure the athlete's safety from any contamination or any banned substances which may result in detriments to the athlete's health or any bans and fines within the athlete's sport. So lastly, the Association for Nutrition has a code of conduct which includes guidelines such as the nutritionist should only work within their scope of practice, act in the athlete's best interests, and conform to any relevant laws and legislations, which basically just protects the client as well as the nutritionist within any legal or ethical situations. Question 1 for female runner. The International Olympic Committee states that pressure from sport to lose weight and the idea that the lighter an athlete is, the better and faster they are, leads female athletes to practicing restrictive weight loss methods, resulting in low energy availability, which can result in further risks and symptoms. So they suggest that it is the health professionals' ethical and moral duty to educate the athlete on the importance of energy intake and the risks that they are putting themselves at when restricting calories and practicing such methods. Coaches and the athletes team should also be educated. This may be really important to for this particular client, as she has stated that she feels that she eats fine and she clearly does not want to gain any weight, as she has expressed from her previous injury. She said she gained too much weight. So following this intervention, she will most likely gain weight. So it will need to be explained to her that this is the case and this is healthy and will aid her in the long term. So next, the International Olympic Committee states that disordered eating should be identified as an injury, and the athlete should not train or compete, as the added energy expenditure from this is putting them at an even lower energy availability, putting them at higher risk of symptoms of relative energy deficiency in sport, which may be very detrimental to and may result in very bad effects on their health and performance. So therefore the athlete this particular client will need to be withdrawn from their training and competition whilst they recover their energy availability. Also, due to the amount of time that the client has had amenorrhea, it may suggest that she has had very severe bone loss. So the intervention may not ultimately be enough to recover that bone loss and recover her bone health. So it may be the case that she will need to have some other pharmacological therapy, which I will not be able to legally prescribe. So I will have to refer her to a different professional who can legally prescribe such support and offer such support, as it is not in my scope of practice to offer such support. Lastly, females are naturally smaller and have greater lean body mass and lean body mass to fat ratio. So with most research being conducted in male athletes, when researching to make recommendations, I will have to make sure that the research is relevant to the client to ensure that I'm working within her best interest and providing the best recommendations possible that are relevant to her, as well as maintaining high standards of scientific integrity, which is following the guidelines of the Code of Conduct of the Association for Nutrition. Question 2 for the female runner. Okay, so if the athlete wants to, the athlete's coach wants them to use a supplement to reach certain effect. Firstly, UK Sport, UK Athletics, and the World Anti-Doping Association suggest that food sources should be used whenever possible instead of supplements to reduce the risk to the athletes' health and safety, and as well the risk of ingesting banned substances, which may result in bans and fines within their sport, stopping the athlete from performing ultimately. And so, therefore, what I would personally do is have a discussion with the athlete about the type of supplement that the coach is recommending and the desired effects that the coach is wanting from this supplement, and explore whether this cannot be achieved within this intervention or through recommendations using food sources. Following this discussion and recommendations, if the athlete is still adamant that they want to use this supplement, and the coach is adamant that they still want to use this supplement, I would suggest that this supplement is chosen using the Informed Sport program, which is basically an assurance program that ensures that the supplement has no banned substances in it, or the supplement is not banned, and the supplement and ingredients are in accordance with the World Anti-Doping Association's guidelines, and ultimately that will mean that the supplement is safe for the client to use, not only as it's free of banned substances, but also to their health, as it reduces the risk of contamination and side effects.